The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Good evening and welcome to our final live program of Your Health, Your Choice. It's Wednesday, the 6th of December. And if you have been experiencing headaches recently, this is a program for you tonight. We're going to be looking at the causes. We're going to be looking at how you diagnose the headaches, taking history, the types. There are actually 3 types of headaches that we're going to be looking at. Tension headaches, migraine headaches, and cluster headaches. And then there's something called trigeminal neuralgia as well to be explored. So we have with us once again our in-house consultant, Dr. Claude Khan, community diabetologist and family practitioner. And over the last year, as this is our last live program, we will be having obviously the
last live program for 2017.
Yes. Yeah, well, yes. Reconsidering that. We will be opening the phone lines a little earlier than we normally do, and the number will be 652-4855. But we just wanted to recap a bit, over the last year, some of the programs that some of the issues that we've been exploring on Your Health, Your Choice. I know we looked at eyes, we looked at leg cramps, back pain, teenage suicide and bullying,
depression. So, I mean, we have covered, and of course, diabetes, hypertension, high cholesterol, the bread and butter kind of medical problems, heart disease, cancer. So, what we've tried to do over the last years cover the straightforward medical problems that we see day to day, but also some of the more the things that are more under the surface, like depression, emotional pain, and then suicide. And we then talked about bullying, I think, also.
Teenage issues, yes. So again, Your Health, Your Choice is really a community outreach program and helping you to educate yourselves on and make wise decisions with regard to your health. So we move on now, I guess, to the first slide that you want to show us on headaches.
One of the things that people may be saying as well, why are we doing headaches?
Yes.
Because again, this is not my specialty area, but having done family medicine for about 10 years in the UK before doing diabetes as a subspecialty, headaches was one of the most common presenting symptoms. And it's a headache to diagnose the cause of, no, it is. Because it's not very straightforward, as we'll see tonight. So what we wanted to do is, as we round off the programs for this year, is just touch on this area and look at, how important it is to look at the history, etc. But I'm going to bring up slide 4. Now we're doing it slightly different, right? So on this slide, we see some very important data, what we call primary causes of headaches, and headaches due to something else. So you see, Linda, here, about 99% of headaches might be due to tension type headaches.
That's quite a high percentage,
yes.
So just 1% of something else.
Sorry?
Just 1% caused by something else.
No, right, so primary causes, there are about 5 or 6 causes. There's tension headaches, migraine, stabbing headaches, exertional, cluster, and then less than 1%. So on the right-hand side of the slide, you see that less than 1% might be due to things like meningitis, encephalitis, head injury, vascular or bleeding. And then the big one that everybody's concerned about is brain tumors. So we can just come off that slide for a minute.
Yes.
So when we say primary causes, actually what we mean by that is we really don't know what causes those types of headaches. So really we don't know what causes a migraine. We don't know what causes tension headaches or cluster headaches. But they are the most common types of headaches. And yet as I say, when people come in with headaches, I think the common concern is this a brain tumor? Is this a bleed of some type? And yet those causes are less than 1%.
Okay, so how would you go about making a diagnosis of a headache?
So we're going to go on to slide 6, which talks about the importance of doing a proper medical history. So I'm just going to go through this and then come back and talk about the history taking. So we're saying that the most important aspect of diagnosing a headache is the history. So what you want to ask is, how often, for example, do you have these headaches? Are they related to something else? And I'll come back to that. At what time of the day or night do they come on?
So you would suggest that as a patient, we take a list of these questions and have the answers ready before we go into...
Yes. So
before we go into the...
Well, it might be difficult for patients to remember all of that. But for example, how old were you when the headache started? So if somebody comes in and tells you they're now 45 and they've been having headaches since they were 10 years old, well, it's not going to be a tumor.
Okay.
For example, it's probably going to be more a cluster headache or maybe migraines. How does it start? Very, very important question. Does it start with an aura of some type? And we'll come back to that. And is it related to something else? So what of the things might be, is it related to a trigger factor, like bright flashing lights, or working on the computer, or a type of food? Because even food allergies, Linda, can be
a source of headaches. Yes.
Absolutely. How long does it last? So somebody might come in and say, well, I have this headache, it's just like a stabbing sensation and it lasts for 5 minutes. Well, that's not like a migraine. A migraine would usually last for a few hours. Does anything bring it on? And then what helps? Very important question. What helps? Because, for example, if you find that it's something the patient says, resting in a dark room, that immediately helps you to think, well, this might be a migraine headache. Or they may say going on a holiday helps, or leaving home helps. So it might be tension or stress that might be causing it. So the history, the point I'm making here is before we rush in to scans and...
those are quite expensive.
Right. We need to look at some of the common aspects of the history, and that takes time, of course. It's so much easier, Linda, for us as doctors, as a patient comes in and says they have a headache. Well, let's do a CT scan.
Or let's just write a prescription.
Absolutely. And very often we are missing the pathology that is involved. Because what I want patients to remember, and by the way, when we open the telephone lines, I would just say that we are not just wanting you to ask about headaches, as it's a final live show. If you have questions on diabetes, hypertension, you're more than welcome to ask those questions as well. But a lot of patients are disappointed because if they come in with headaches and you have not taken a proper history, and then they go and spend $5,000 on an MRI scan and there's absolutely nothing, that could be quite depressing. Apart from spending money that might be may not have been necessary, you have not taken the time to take a proper history. So as you were saying, Linda, maybe patients should think about some of these questions before they come in.
I remember as a 14-year-old having headaches, and it was due to eyesight problems.
Right.
So rectifying it with glasses was a solution.
So, one of the first things I would say to patients who come in with headaches, especially if it's teenagers, etc., is, have you had an eye test recently? Okay. I mean, that's a basic thing. Doesn't, take much to have your eyes tested, and it could just be a simple eyesight problem, especially if you're sitting at the back of the class and you're trying to read.
Yes, that was the thing, sitting where the position in the classroom but there was a lot of chalk and talk in those days, so you had to copy notes and things. But yeah, the headaches got worse and worse the more you strained your eyes.
Right.
So yeah, I guess that's one of the first things we should do when we have headaches. Maybe go get an eye test.
Well, I think yes, unless it is a catastrophic onset. What do I mean by that? If somebody really comes in, we said that less than 1% would be a vascular cause. But if somebody comes in and says, I was just resting at home yesterday and I had a sudden bang at the back of my head, that's a red flag.
Yes.
Especially if that person is in their 30s and 40s. That would make me think, yes, maybe I need to get a scan on this patient fairly quickly.
Okay.
But if it's a long history of, headaches, and we'll describe the difference between tension and migraines, then getting a basic eye test is quite in order as a first step before you do anything else.
Okay, so we've looked at causes, we've looked at the way you go about a diagnosis, we've looked at history taking. What about, we mentioned 3 types of headaches. I think you mentioned tension, you mentioned migraines, and you mentioned cluster headaches.
So the first one, which is the most common, coincidentally, and people may find this strange, is tension type headaches.
Okay.
And it's slide 8. So if we can bring up slide 8, we will have a look at this. Right. So there it is. Tension type headaches. So frequency. Tension type headaches are often chronic and daily. So this might be going on for years. The pain is mild to moderate. It's like a pressure or tightness around the head. It can last for 30 minutes to 7 days, and it can be both sides or the whole head and the neck area. And there's no relationship to light or sound sensitivity, and there's no aura. So we can just...
What do you mean by an aura?
Right. So when we come to migraines, we're going to explain what an aura is. An aura is almost like a premonition. It may be just sort of flashing light, or you might have a slight alteration of the visual field, and it's a warning sign that the headache is coming on. And people learn that when they get that aura, that the migraine is, and that is typical of migraine type headaches.
So you can learn what induces the headache.
And we will come to trigger factors for migraines later on. So tension type headaches, of course, is often due to stress. And
that's a nice one.
Yeah, if we can bring up slide 9, the next slide, which is the clinical characteristics of tension type headaches. So you can see stress, emotional, being upset, leading to pain, and you can have anxiety or depression associated with it. The pain and an acute episode of tension type headaches can last for most times less than 15 days, but then it can become a chronic problem. And you can see from the left side of the slide, the site, it can be bilateral. That means on the right or left side. Or it could be just right across the top of the head.
So that's the red portion.
Right, yeah. It could be like a hat or a sort of band around the head, and or just pressure and aching.
Right. So like the throbbing on the
Yes.
What do you call this again?
That's a temporal area.
Temporal area.
Yeah. So let's just come off that. You wouldn't have seen where Linda was pointing to.
Yeah, this bit.
Right. So here we are saying, Linda, one of the most common types, or the most common reason or diagnosis for a headache is tension type headaches, and it is stress related or emotional upset or pain. Now, no scan is going to show that.
No. So you have to take a history.
No, and no blood test is going to show that. Now, of course, patients have to have a certain level of insight into what's happening in their lives to be able to come up with this diagnosis, because, I have to say, a lot of patients want a fancy diagnosis. And when you tell them it's tension or stress-related headaches, I just get the impression patients are sometimes not too impressed with that.
But we have done a program on beating burnout and
Yes.
the various factors, you know, stress factors,
Yeah.
stress inducers, and so on. And I think stress, I mean, yeah, we know that a certain amount of stress is good for performance, for, you know, getting that adrenaline going. But too much stress causes things like this.
Absolutely. And you know, we continue to say we live in a very stressed society. You know, driving from San Fernando to Port of Spain, if you're working, leaving home at 4 in the morning, getting back home at 8 at night. I was talking to a few patients today. They have kids getting into the SCA rat race, I would call it, lessons, and people live very busy lifestyles, and burnout, so stress can lead to burnout, and burnout could lead to underperformance, and then you have the financial, so it's a knock-on vicious cycle. And it's not an easy problem to diagnose, obviously, tension headaches, because, as I said, if you don't take a proper history, you're not going to be able to come up with this diagnosis. And even when you come up with a diagnosis, the question is about treatment. I mean, how do you treat tension headaches or stress-related headaches? Well, the problem is, if you rush into medication, and some people may need medication, you could become dependent on painkillers.
Okay.
And there's actually a type of headaches related to
Dependency.
on codeine type or opioid type headaches, where you become so dependent on these painkillers that if you don't take them, you get headaches as well.
Okay, so we move on to migraines then.
So, sorry, migraine. So, of course, this is another common, we said there were 3 common types of headaches.
So we've done tension, we're looking at migraines, and then we look at clusters.
Right. Okay, but just before we go on to migraine, we may not have time to come back to treatment. So if we're talking about, and we make a diagnosis of tension type headaches, then we may have to tell that patient, well, you need to go away, learn how to relax, learn how to de-stress.
Relaxation therapy.
Relaxation therapy. I mean, acupuncture is becoming very popular now. You know, people have different views on acupuncture, but I know a lot of doctors are actually suggesting acupuncture or meditation, if you believe. And there are different types of meditation. I don't want to get into the philosophical aspects of it, but basically, it is trying to be introspective and learn how to unwind. And this is a personality-driven thing too, because, you know, if you have a type A personality, like some of us on the set, you're constantly driven to do things. To lay back and enjoy a holiday is often very difficult.
That's right. Yeah.
Yes. So we're
Working holidays are the order of the day.
But of course, the problem with us now is that even when we go on holidays, we have our smartphones and we have WhatsApp and we have, so WhatsApp? WhatsApp, sorry.
Yeah.
You got it right. Maybe it's because you spend so much time on it, right? So,
we're getting an indicator that it's time for the first break. Yes.
Oh, I'm enjoying this program so much.
Yeah, so we'll be joining you in a few minutes. Don't go away. We're continuing to look at the different kinds of headaches. So far we've examined the tension-induced ones, and then we look at migraines and clusters when we return.
That's right, people. It's that time of year again, and we here at ACTN The Voice have got you covered. All your favorite Christmas music and movies every day.
Wait, did you say every day?
Jingle bell.
Yes, every day. Tune into ACTN The Voice as we spread the good news of the true meaning of Christmas. No one does Christmas like us. ACTN, the voice of Christmas. We're bringing Christmas to you with all your favorite artists. Don't miss Bring the Rhythm Christmas, Monday 18th December to Friday 22nd December, 8 p.m. nightly, live on ACTN, the voice of Christmas. ACTN, the voice of Christmas.
Okay, so you've got 12 pairs of ribs. We're looking at your health, your choice tonight, examining the issue of headaches. Now, it seems like quite a trivial thing to be concerning ourselves with on a program like this for some people, but if you have been suffering with one and you're not quite sure of the causes, this is the program for you tonight. So we've looked at some of the causes. We've looked at the diagnosis, how we take a history. And we've examined the first type, which was the tension-induced headaches. Now we want to look at migraines, and I know you have an interesting slide for us to share.
We're going to show slide 11 in a minute, but Linda, you said it might be trivial to some people, but actually there's a lot of lost working hours as a result of headaches. People, if you get up in the morning with a terrible migraine, you're just not able to get to work. So lost hours, productivity and the economic knock-on effect is significant. So I think this is a back pain and headaches are two of the most common presenting symptoms to general practitioners. I mean, I don't see it a lot because I do mainly diabetes, but again, when I did family medicine, it was one of the common symptoms. So we're going to go on to slide 11.
Yes.
And this is migraine. So this will be common to a lot of people. And in brackets, you have half head.
What is that?
No. Okay, so typically a migraine will present on one side of the head. Now remember, with tension headaches, we were saying it's often the whole head, like a tight band. So that's where the history is very important. The frequency may not be as much as tension headaches, but it can vary from 1 or 2 per year to 2 or 3 per week. So there's a wide variation. It could be moderate pain, but it could be severe pulsating, throbbing. The duration is can be 4 hours to 3 days. And usually, as I'm saying, it's one-sided, but it could be from in one attack, it may be on the right side of the head, another time it may be the left side. And symptoms, so we talked about aura, but you can also have nausea, vomiting, sensitive to light, sound, smell. So we can just come off that slide.
I think from a personal experience, I've had that maybe about 2 or 3 times in my life. And it started off with like a searing pain in the back of my eyes. And just, again, sensitivity to light was very important.
So remember we were saying tension headaches. There's not that history of lights, photophobia, as it's called, or sound, loud songs, which is one of your favorite pet peeves. But often it's associated with nausea and vomiting. And that's quite important, because if you take oral tablets and you have nausea and vomiting, obviously the efficacy is and that's why in treating a migraine, very often people would have to come into the doctors and take a injection of gravel, for example, and a normal anti-inflammatory injection like Olfen or diclofenac, as it's called. That's Olfen. And if you take that orally, it doesn't work, but when you take it by injection, it works.
Yeah, it's again to do with the absorption.
Because when you have nausea and vomiting, you have stasis of the stomach contents, and it's not absorbed. The different, immediately you're seeing a bit of difference between these two diagnoses. Tension headaches, it's a whole head, whereas migraines is often just one side. Interestingly, it's more common in women than men. And if you ask me why, I wouldn't be able to answer that.
You wouldn't. Because one of the things that I've obviously shared with a lot of women on migraines, certain common factors would be diet, for example. Like when they, for example, eat a lot of dairy or citrus, it tends to induce a migraine.
Yeah.
So they have to cut those things out.
Those are triggers?
Yeah.
Okay. And there's even something called menstrual type migraines, where in the period just before the menstrual cycle starts, just before that week, you can actually have PMT, premenstrual tension, and headaches can be associated with it. So it's more common in women than men, and it can often start from a teenage years. I just want to remind people that they, in a few minutes, they can start calling in.
Yeah, the number again, 652-4855, 652-4855, if you have any questions. It doesn't have to be connected with tonight's topic, headaches, but if you are in need of any kind of advice from Dr. Khan on anything diabetes related, or are you willing to handle anything else?
Yeah.
Yes?
You can call
anything
in and
else?
ask their
Just call in and ask your questions. So 652-4855.
So we have another nice slide here, which is slide 13. What happens during a migraine? So I think this is slide 13, right? So I'm not sure how clear people are going to see this, but you can see that you have the normal period at the left of the slide, and then you go into the prodromal period, where you might be heightened perception, fluid retention, just a craving, and then you have the aura, which could be just flashing lights, the field of sight can be affected, and then the actual headache period, which is the third phase, where you can have the anorexia, you have the photophobia, loud sounds, vomiting, and then you have the resolution is a deep sleep.
Right. We have a telephone call. Yeah. Yes. So first for the evening. Good evening. Can we have your question, please? Call. Yes.
Good afternoon.
Good afternoon.
Dr. Khan and Mrs. Khan.
Yes.
Good evening.
My question today is not about headache.
That's okay.
I am 65 years of age. I'm a diabetic.
Can you turn your television
to go
down?
And do a lot of tests. Most of it came out very well, but he said there was a little something on the kidneys.
Okay.
So I want to know, doctor, I was telling a friend about it. She said that peas not good to eat, neither red beans not good to eat. So I want to know if that is true.
Okay.
I don't want my kidneys to get more worse. Right. If it's something I could do with my diet, I will try my best to keep up with it. Okay. Thank you.
But can we just ask, when you call in, if you can turn your television sets down, because we get a lot of feedback here and it makes it difficult for us to actually hear your questions. We did hear that question, but there was some feedback. So if you could turn your televisions down, that will help us tremendously.
So, can I answer that question?
Yeah.
So, chronic kidney disease is often associated with type 2, well, diabetes. And you can have from grade 1 to grade 5. And when a doctor says there's a little problem with the kidneys, it could be just stage 3, which is a very early stage. And it may not progress at all. So the key things to prevent progression of kidney damage is good blood sugar control, of course, good blood pressure control, and there's some new guidelines for blood pressure. We want to get people's blood pressure down to about 130/80. Good cholesterol control, and yes, your diet is important. So you may need to see a dietitian, and basically you may need to think about a renal diet. And a renal diet is basically trying to exclude any foods that are high in potassium.
So is she right about the beans?
The beans, I believe, yes, you have to cut back on it. But what confuses patients is that when you're diabetic, we say that you should have whole wheat, you know, the multigrain whole wheat, and oats, etc. When you have kidney problems, you're told to go back to white flour, white rice, stop eating the oats, things like coconut water.
So you want things that are easily processed with a renal diet?
I'm not sure if easily processed is the right word.
Or digested?
No, it's foods that are simply high in potassium.
Okay.
So you want to omit from your diet. So even some types of fruit, you have
Bananas.
to be careful. Bananas.
Yeah.
So the beans and the peas, yes, I think you need to limit that. But more importantly, if your doctor said it was just a slight thing on the kidney, really you want to focus on good blood pressure and good blood sugar control. So don't miss that. The diet is important, but don't miss the importance. Yeah.
Okay, so you were going to show us something about migraines again.
We were just going to say that with migraine, you can have a strong aspect of inheritance, so a genetic predisposition. And people often don't know that, or they don't think about that. They think about diabetes, that it's a genetic thing, the hypertension, but when we talk about migraines, people don't think about the family history.
Yeah.
So you can have a genetic predisposition, and some people just have a lower threshold to spontaneously develop headaches. I think we have another question.
Good evening. Can we have your question?
Yes, hello. I have at the back of my neck a boil that came out, and I called the pharmacist and spoke to her, and she said I could use some warm soft candle. I have been using that, but it's the pain has subsided, and it seemed to be coming to a head, but it's been going on for more than a week and a half, and I'm a little concerned about it.
Are you diabetic?
No.
And the boil is where?
At the back of my neck.
Okay.
Right on the hairline, a little into the hair.
Right. So
Soft candle.
Right. So soft candle. That's an old-fashioned remedy, and I don't want to say that it's not appropriate. What may have caused it is the root of the hair can get ingrown, and you can form a boil or a cyst. Now, she's not diabetic, which is good,
yeah.
Because with diabetes, a simple thing like that, I've seen people come in with just a little sebaceous cyst on the back, which most times will resolve in people who are not diabetic. And I remember one person recently came in, and I had, fortunately, I referred the patient to Dr. Beam, who works with me, who's a surgeon, and he had to actually incise and drain it. There was a lot of pus under the skin.
Yeah.
So what I would say to this patient is, I'm a little bit cautious. It may look as if it is resolving, but you have to be sure that you don't need antibiotics. And the soft candle is, as I said, it might have drawn out, as some people say, some of the inflammation. But I think, you know, if there's some swelling still there, you really should still see a healthcare professional to give you some advice.
Okay. So would you want to explore some of the triggers. To that,
so
to migraine?
This is slide 15, I think. Triggers. Slide 15. Right. So, Linda, you said that you had advised some of your friends about citrus.
No, they told me that when they ate citrus or when they ate dairy, that it tended to induce the migraines.
Right. So here we have about 5 or 6 different aspects of triggers that can cause migraines. And this is very important in the history taking. Foods, spices, wine. It's a common thing, especially cheap wine. Chocolate, citrus, food additives. So
monosodium glutamate.
Yes, that's one that it's present
common
in lots of foods.
Yes.
Too little sleep. But then this slide also says too much sleep.
So you have to find out what's the right.
Well, we
right
usually say 7 to 8 hours. And then stress and female hormones. So we'll come back to that. But I think we have another question.
Okay, good evening. Yes, can we have your question, please?
Good afternoon.
Hi.
The other day I was listening to your program about the legs.
Yeah.
I normally get pain in my leg. And the doctor told me with some L1 to L5 with the spine or something with the space. What do you think I can do right now? Because I do not want those.
Did you do an X-ray or?
I did an MRI some years back in Mount Hope.
Some years ago. And is it the basis of that you're being told? Did that MRI show compression of the disc spaces or anything?
Yeah, it showed a compression.
Okay. Well, I'll try to answer it on camera. So the MRI scan is the common way of looking at the back and looking at whether there's a pinched nerve, as we call it. Now, I didn't go into all the details of the history, but remember when we did that program on leg pains, we were saying it's important whether the pain is on one leg or both. Now, normally if you have a pinched nerve, which is sciatica, and the pain will be shooting down one leg.
Side.
If you have pain going down both legs, it could be something like spinal stenosis, which is narrowing of the end of the spine. So, you know, if in fact you have disc space narrowing, it is not an easy problem to treat. You may need to see a neurosurgeon.
She should probably do another
well, if it was a few years ago, yes. Yeah. And if the leg pains are getting worse, then you need to see a neurosurgeon. You may need physiotherapy, or there are drugs like Lyrica, gabapentin, Cymbalta, which can help together with a normal painkiller for leg pains.
Okay.
So I'm not going to go back to the slide, Linda, but
the triggers for migraine,
sleep, stress, we talked about that also. And well, maybe the reason why females are more affected is that estrogen levels, especially you know, during the menstrual cycle, when you come to the premenstrual time, I see we have to go to a break, you have estrogen levels falling, then that can trigger off a headache.
And that's connected to probably to the premenstrual headaches as well.
Yes.
Okay. Right, so we've been examining headaches this evening, quite a common health issue. When we come back, we'll be looking at the third type of headache induction or headache-induced cluster headaches. And there is also the idea of trigeminal neuralgia that we want to explore. But keep your questions coming, keep phoning in. When we come back after the break on Your Health, Your Choice this evening, our last live program for 2017.
This is Apostle Judy Karim of the Greater Love Christian Center, inviting you to join us every second and last Tuesday of the month on ACTN The Voice, as we bring to you the Word of God that will challenge you, bless you, and take you into your greatest life ever.
Welcome to the new season of Football 101. I am your host, Joshua D'Amatos.
Well, it's time for your weekly football news update. I love you, Messi.
Unfortunately, kiss the badge, kiss the badge. Oh,
What's that?
Welcome to this edition of The Interview, and as you can see, I'm not alone on the set. I have Marcus, a Liverpool fan, and I have Shaquille.
We're bringing Christmas to you with all your favorite artists. Don't miss Bring the Rhythm Christmas, Monday 18th December to Friday 22nd December, 8 p.m. nightly, live on ACTN, the voice of Christmas.
So if you want to live behind walls all your life and live an isolated, lonely, miserable life, go ahead. But I suggest that you tear down all your walls and let God be a wall of protection about you. And he says all of your walls will be called peace.
ACTN, the voice of Christmas.
Welcome back to Your Health, Your Choice. It's Wednesday, the 6th of December, 2017, our final program or live program for the year. However, we are on Facebook. If you go to ACTN The Voice on Facebook, you can see us live, but we also have replays, and you can also send your messages. Before the break, we were looking at migraines, and we mentioned the word aura.
Yeah.
Yes?
So people have a few more minutes before we end to still ring in.
Yes.
But can we bring, I think this is slide 16. Just showing what an aura might look like. So, you know, you might be in a room and half of the room is blanked out. And then the very next slide, which is slide 17, you might be reading a page and that pieces of some of the letters,
text,
or it might just be zigzag lines. So that's what an aura looks like.
Okay. Right. So we've examined tension headaches, we've examined migraines, and now we're going to look at clusters.
Cluster headaches. So this is in order of the common ones. So we said tension headaches are the most common types of headaches. Then we have migraines. Cluster headaches. I think this is slide 20, if I'm not mistaken. Slide 20, yes. Is that right? Cluster headache. So frequency, every time it tends to occur at a particular, now we say season. Of course, in Trinidad, we don't have the 4 seasons, like a temperate climate, but it might be more common in the dry season or the rainy season. The pain can be excruciating, penetrating, boring, continuous, non-throbbing. It can, now notice duration, it can last from 15 minutes to 3 hours, whereas migraines last more like 4 hours to a few days. And always on the same side. Remember we said migraine can occur on either side, but normally on one side in each episode. And tension headaches are more like a band around the head. And you can have watering eyes, nasal stuffiness, runny nose, red eyes, swollen eyelids, sweating.
No, so lots of symptoms for cluster headaches.
We can come off that slide. So so cluster headaches, again, you can see the difference in the presentation. And remember, we started off by saying the history is extremely important. And you can see a definite difference if you take a proper history between the tension headaches, migraine, and cluster headaches. And one of the things about cluster headaches is that the typical patient might be a middle-aged male smoker.
Okay.
So for some reason, it's linked to smoking.
So migraines are more connected with females and cluster with males.
Yes, yes. And the next slide is it's a nice one. I think it would be the very next slide, 21, I think, yeah. So look at the clinical characteristics of the cluster headache. It's on one side, and so it tends to always occur either on the right or left. And it can occur just in the eye area, and it's stabbing in nature. And as I said, because of that, you can have red, watery eye, drooping eyelids, runny or and congested nostrils.
Oh, so when I had that searing pain in my eye, it was a cluster headache, not a migraine then?
If we can just come off that, come off the side. Can you say that again?
I said the 2 or 3 occasions when I've had these headaches, it started off as a searing pain in my eye.
So it could be a cluster.
But I was sensitive to light.
Right. So, you know, the thing about that is it could have been a cluster headache. But how long did it last for would be an important question. If it was...
yeah, I went to bed and by the next morning it was gone.
Right. So very interestingly, it got better with rest.
Yeah.
Whereas a cluster headache may not be directly related. I think we have a question.
We have another question. Yes, good evening. Can we have your question, please?
Yes, ma'am. Good afternoon.
Good evening.
Good evening, yeah.
Yes, so what is going on with me? Both my feet are swollen. I'm a triple bypass patient. Now they're telling me they're hearing a murmur. I want to know where I go from here.
Okay. So, excellent question. And, you know, again, this is one of the common symptoms. We see swollen legs. So let me just say, first of all, that swollen legs could just be due to gravity. What do I mean by that? If you're sitting all day with your legs hanging over the side, and you have varicose veins, for example, the fluid tends to drain to the legs, and then when you elevate the leg at night, it improves. So by the morning, the swelling goes down. So that's important to ask the patient, does the swelling improve overnight? The second thing is there any associated shortness of breath? Because if you have swelling of the legs with breathing, shortness of breath, or chest pains, etc., then you're thinking it could be a heart problem.
And she said she's a triple.
Right. Well, she had a triple bypass, and she's now being told she has a murmur on the heart. So what I would say is, have you had an echocardiogram? Because were you told, so the question is, was the murmur based on listening to the heart, or was it based on doing an echocardiogram? I would say if you have had a triple bypass, and you have a murmur on the heart, you need to have an echocardiogram done, which is just an ultrasound of the heart, basically. It's not very expensive. You might get it through the hospital, but often it has to be done privately.
So that's the next step for
I would say that's the next step, because it will show you whether there's any degree of what we call heart failure. So if there's heart failure, you can have a backup of fluid into the lungs and also swelling of the legs. So I would say an echocardiogram.
Right, so we move on now to that interesting terminology, trigeminal
neuralgia.
Neuralgia.
Right, and I think this might be the next slide. Trigeminal neuralgia. Yep. So trigeminal neuralgia is very distressing. It's a very distressing symptom. I remember having a few patients, and again, unfortunately, women again, very common in middle-aged or elderly women for some reason.
Estrogen levels.
Okay, well, it could be after the menopause, and it could be a knife-like searing pain, and it's on one side of the face, and trigeminal neuralgia is associated with one of the facial nerves. and neuralgia means nerve pain. So we can just come off that slide. Now, this, as I say, can be very distressing. There are newer treatments becoming available, but very often you would have to be on something like Lyrica or carbamazepine, Cymbalta, which helps with the nerve. And one of the things about this also is that eating can often trigger the pain, or chewing.
Yeah.
And in England, in particular, what some people found was exposure to cold, the wind, could just trigger off the pain. So trigeminal neuralgia, not that, when I say not that common, I don't see that commonly. Well, I don't do much family medicine here. I do many diabetes, but I think it's further down on the list, and it's fairly easily diagnosed by the pattern that.
And how do you treat trigeminal neuralgia? How do you treat it?
So what I'm saying, there can be a surgical intervention by actually exploring the nerve itself, but more often it's drug therapy. So it's Lyrica, which is a pregabalin, which is a common tablet. And let me just say about Lyrica, you know, a lot of people have bad reports, bad press about Lyrica. A lot of people take Lyrica and have no problems at all.
But some people do.
Yes, I know. I remember your dad I put him on Lyrica for one night, and he had a terrible, sorry, laughing and down.
Terrible episodes.
I remember him telling me, never put me on this drug again. So some people can have a bad reaction to Lyrica. But it's like, you know, it's like any drug. You can put 100 people on penicillin, and then one patient comes in and they have an allergy, a severe allergy to penicillin, and it makes it very, very difficult.
Okay, so let's have a look at some general pain relievers. We have about 8 minutes left on the program.
So yeah, let's just go to slide,
general,
we're going down to general causes of general treatments, and it's slide 26. Slide 26. Yeah. So how do we treat these different migraine headaches, tension headaches? Well, now we see aspirin here, but you have to be a little bit careful with aspirin because of stomach lining. Just simple Panadol, and that can work for a lot of people. Ibuprofen, and you can use it, it's safe, but again, in the elderly, you have to be a little bit careful with ibuprofen. And then codeine and tramadol. Tramadol is Trabalin, or Tramacet. What you have to be careful about is the long-term use and addiction.
Codependency.
Yes.
Yeah, dependency on it. Okay.
Yes. So I think we only have about 5 more minutes. So let me just wind up with migraines. They're the very strong tablets like Imigran, Zomig, Maxalt, or Relpax. Now, these are fairly expensive, and it's not like typical painkillers where you take 5, 6, 7 for the day. It's normally you feel the migraine it's coming on, and you take the tablet in the prodromal period, so it can be absorbed, and that can solve the problem. Now, and as we wrap up this, one of the things is if the migraines are happening very frequently, you then go to prophylactic treatment. By that I mean taking a tablet every day to prevent the migraine.
Yeah.
And that's preventative treatment. And again, the tablets are tablets like Tegretol, amitriptyline, and there are others that are available now. So, but that would only be for people who are having migraines like every day, 2 or 3 days, and it's really affecting their lifestyle.
Would you say that a lot of patients come in needing that kind of prophylactic?
No. Okay. I think it's the exception. I mean, generally, when I used to see patients with headaches, they may have one a month or two a month. Now, if that's the case, I would give them more something like Imigran or Relpax, just to treat that particular episode. And of course, and of course, you often can just deal with the underlying factors, stress, etc.
Okay. Right, well, I just lost my my Christmas corsage, but
well, we only have 3 more minutes.
We have 3 more minutes on the program, so if you want to put on your pastor's cap and share something of a Yuletide.
Yes, we're in the Advent season. I just want to say that as we wrap up tonight, we've been doing these programs for the last few years, and it comes from the Anapausis Center, which I just want to explain the word Anapausis. It's a Greek word for rest, renewal, and restoration. So the ethos and philosophy of the whole center, which is made up of the medical center, which is at number 10 Lance Street in Vistabella, and now the church, which is the Trinidad and Tobago Anapausis Chapel, that's at number 12 Johnson Street in Coquille, very visible. We're very bright, lighted cross at night. And then, of course, you have Lengua Linda, which is the teaching arm, English, Spanish, and ESB, English-speaking board.
So that's training in public speaking.
Public speaking.
Debating as well.
Right. So the number, if you want more information about all of those, it's 482-4269. So Advent is leading up to Christmas. And in fact, from this Sunday at our church, 9 a.m. on Sunday mornings, we are starting a series called Journey Towards Christmas, Following the Star. And we're going to be following the Christmas star, the Star of Bethlehem, that gives us hope, that gives us joy, that gives us peace. And then on Christmas morning, which is, by the way, going to be at 7 a.m., our service will be at 7 a.m. on Christmas morning, 25th of December, of course. We will be looking at the greatest Christmas gift of all. So what we are saying is that in the Advent season, we can get caught up with all the peripheral things. Giving of gifts, very important. But far more important is celebrating the birth of our Lord and Savior, Jesus Christ. And as we focus on celebrating Jesus, it can give you joy, it can give you peace, it can give you hope. And one last thing is to remind you, only as a night, you're more than welcome to come and visit our church at 9:30 p.m. where we welcome in the new year. Linda, you want to close off? I think you have maybe about 30 seconds.
This is our final program. I've been told that time is up. So we'll see you again in 2018 for a new edition of Your Health, Your Choice.
But there will be repeats?
Yes, there are repeats. There will be repeats. And remember, you can go on Facebook to ACTN The Voice, and you can leave your messages there as well. Good evening, and have a Merry Christmas, and we wish you all the best for 2018.